Good morning and welcome to today's clinical meeting. Our first presentation is from Medicine 3 by Dr. Shrithi, Masquerade.
So good morning to one and all present here. Today I'm going to present on behalf of Medicine 3, Masquerade. 53-year-old male, Mr. E from West Bengal, was admitted with complaints of fever for 6 months, which was insidious in onset, high grade, intermittent in nature, with chills and rigors. There was no evening rise of temperature or night sweats. Swelling on the left clavicle for the 6 months, which was progressively increasing in size, associated pain, and redness over the swelling. There was history of loss of weight of about 5 to 6 kilograms for the past 3 months with loss of appetite. There was history of breathlessness he noticed since the past 4 months, which was insidious in onset, progressive in nature, and the effort intolerance reduced from 1 kilometer to 500 meters. However, there was no paroxysmal nocturnal dyspnea or orthopnea, and there was no history of chest pain, palpitations, abdominal pain, jaundice, vomiting, or altered bowel habits. Past medical history, he had progressive painless decreased vision in bilateral eyes over the past 3 years, and there was history of complementary alternative medicine intake. And he was also a known case of type 2 diabetes mellitus since the past 20 years on irregular medications. Personal history, he consumes a mixed diet with normal bowel bladder habits, and he was a tobacco consumer. So vital signs on examination, the positive findings mainly include he had a temperature of about 102 Fahrenheit, pulse rate was 104. There was pallor, there was elevated jugular venous pulsations, and on local examination of the musculoskeletal system, there was a warm and a tender swelling of about 6 cross 8 centimeter, medial end of the left clavicle. It was erythematous, tenderness was present with fluctuancy present. There was no spinal tenderness, or there was no tenderness noticed in any other bone regions. On doing the fundoscopy, there was bilateral proliferative diabetic retinopathy with the left eye vitreous hemorrhage that was noticed. Systemic examination wise, cardiovascular system, first and second heart sound was heard, no murmurs. Respiratory system, normal vesicular breath sounds heard. Abdomen was soft, there was no hepatosplenomegaly. However, there was bilateral renal angle tenderness that was present. He started wincing in pain, right more than left. Digital rectal examination was normal. And central nervous system examination wise, bilateral ankle jerks were present, and there was loss of sensation to pain and temperature on the left and right foot dorsal aspect. So the summary of the case was a 53-year-old Mr. E. He known case of uncontrolled diabetes mellitus. He came with complaints of pyrexia phonenologic, prolonged febrile illness for about 6 months with constitutional symptoms with exertional dyspnea. And on examination, there was a left clavicular inflammatory swelling. There was pallor as well as elevation of the jugular venous pulsations. Bilateral renal angle tenderness was present. And fundoscopy, it showed a bilateral proliferative diabetic retinopathy with a left eye vitreous hemorrhage. The differentials that we considered was probable infective endocarditis or a malignancy, which could be hematological malignancy, multiple myeloma, since there were he had a prolonged febrile illness and some bony lesions also. Then metastatic disease also was considered, like secondaries from prostate, follicular carcinoma, thyroid, small cell lung carcinoma, renal cell carcinoma, or if it itself is a primary bone tumor. And infections also we had considered, like disseminated bacterial infections, including staphylococcal tuberculosis or brucellosis. We went ahead and did the first-line basal investigations, which showed a WBC of 18,400 with a neutrophilic predominance. The hemoglobin also was low. It was 5.4 with the MCV of 75.1. It was a microcytic anemia. And the liver function tests, which showed an AG reversal, total protein of 9.33 and albumin of 2.9. And there was a renal dysfunction. Urea and creatinine were elevated. And there was mild hyponatremia also. And we did BBVS, which was negative, and the baseline infective markers like CRP as well as Procal also was done, and that were also elevated. So since we had our infective endocarditis and all in our mind, we did an echo, which showed a global normal LV systolic function. There was no vegetations. And we screened for the left clavicular swelling, which we said, which showed some liquefied component involving the left sternoclavicular joint and subcutaneous plane. And the superficial component in the subcutaneous plane measures about 4.1 cc. The deep component, it extends along the intermuscular plane to involve the left sternoclavicular joint space also. However, the muscles, intercostal muscles and all were not involved. that was subjected to ultrasound-guided core biopsy, which showed an inflammatory granulation tissue. Special stains were negative for both fungal as well as bacterial organisms. The cultures also were negative. It did not show any atypical cells also. So based on the other clues, we also did for AG reversal, we did a serum electrophoresis, which mainly showed a probable band in the gamma region. We did immunofixation electrophoresis, which was normal. Bone marrow also was done. There is no evidence of light chain restriction. It was mildly hypocellular but trilineage hematopoiesis, suggesting it's normal. Bone marrow cultures, bacterial, fungal, MZ automation, all were negative. Since he had bilateral renal angle tenderness, though he didn't have urinary complaints, but since he had renal angle tenderness, we did an ultrasound as a baseline investigation to look for any other intra-abdominal, any other foci also, which showed on the day of admission when we did, there were bilateral renal non-liquefied abscesses, suggestive of bilateral pyelonephritis. Multiple non-liquefied abscesses were found in both the kidneys. And he was subjected to repeated follow-up every 3 days. On the follow-up, there was, once we started the medications, there were no marginal increase in the abscess. It only showed a stable non-liquefied abscess. And then we got the culture, Staphylococcus aureus, which was methicillin sensitive, so susceptible to rifampicin as well as protriamocosol linezolid. After 48 hours, we repeated a culture. Based on the first culture, we started off empirical antibiotics, but after that also, on the second day also, the organism wasn't cleared. And from 16th onwards, there was clearing of the organism. Every 2 days, we used to repeat. And so though we got this culture as Staphylococcus aureus, we were not very sure that the multiple osteolytic lesions were there. Is there any underlying primary malignancy that was causing the metastasis was our concern. So we had to do a total PSA, which was normal, kappa lambda ratio, which was normal. And the anemia part was also evaluated, which showed an iron deficiency anemia. And then the last resort was nuclear studies. We did the PET CT and the bone scan, which showed increased tracer activity that was seen in the sternum. The corresponding CT images showed destruction of bone component as well as a soft tissue component, and increased tracer activity seen in the left clavicle, first rib, sixth rib, posterolaterally, left ulna and midshaft of the right fibula, which also was suggestive of an expansor lytic lesion. So multiple osseous lesions were there, suggesting HP correlation, which we redid, and again it was an inflammatory granulation tissue. And there was also cortical destruction of the left sternoclavicular joint and the anterior aspect of the left first rib extending into the subcutaneous plane, which represents, based on the histopathology, we asked them and they said it could be a chronic osteomyelitis of clavicle with septic arthritis of the left sternoclavicular joint. And these were the features of the pyelonephritis, like mild bulky and heterogeneous bulky kidneys with probable evolving or resolving abscess. And they were paraiotic and right external iliac lymph nodes, which were reactive, and there was a sclerotic area in the left clavicle, chronic infective etiology or old fracture. So this patient who presented with prolonged febrile illness, multiple osseous lytic lesions, we did extensive workup to look at malignancy, including bone marrow as well as PET CT, and finally we arrived at the diagnosis of disseminated methicillin sensitive Staphylococcus aureus bacteremia with chronic left clavicle osteomyelitis, which in X-ray as well as a CT was suggestive of osteolytic bony lesions, and there was septic arthritis of the left sternoclavicular joint with renal abscess, probable risk factor being an uncontrolled diabetes mellitus. So Staph aureus, as we know, it causes widespread metastatic infection starting from brain abscess, endophthalmitis, pulmonary disease like multiple cavitatory lesions, and their abscess and skin infections with osteomyelitis as well as chronic skin infections. This was a case that was reported in Curious, where a severe case of disseminated multifocal methicillin susceptible staphylococcal infections present in a diabetic patient who presented with a atypical pulmonary nodule. Initially, they thought it was a malignancy and they had extensively screened him. Then he had presented with an epidural abscess with lower limb with paraplegia, and then blood culture grew Staphylococcus aureus, and he was subjected to surgical debridement as well as when the antibiotics were started, he seemed to improve, though the deficits were persistent. So mainly it tells us that early suspicion and recognition of this and early initiation of antibiotics can reduce the mortality and the morbidity associated with this disease. So here we had used FDG PET in the diagnostic workup for the Staphylococcus bacteremia. I looked into a study, a prospective interventional matched control study. So here the patients were diagnosed with Staphylococcus aureus bacteremia, and the control arm, they had the standard diagnostic workup without the PET, whereas the intervention arm, the PET CT was in the diagnostic workup. So the outcomes and the results were that additional infective foci, particularly in the osteoarticular sites, were better identified in the PET CT rather than the non-conventional diagnostic methods, and thereby the mortality also seemed to be lower in the PET CT group in compared to the conventional diagnostic group. So there is a score called as a VISTA score that is to determine the priority of the transesophageal echogram in patients with Staphylococcus aureus. So in our patient, he had persistent bacteremia. That is, even after 48 hours, there was Staphylococcus aureus in the blood. And his C-reactive protein was also 194 at the time of presentation. And he was a community acquired. Like, he was not previously, like, he didn't have any history of intravenous drug abuse. I think it's a community acquired. So it had a score of about 6. So transesophageal echo was also done, which did not show any infective endocarditis. And I looked into the pathogenesis of this Staphylococcus osteomyelitis. It is basically Staphylococcus producing a biofilm, thereby producing resistance and persistence of the infection and dissemination throughout the body is what is mentioned. So this is the diagnostic workup we do for Staphylococcus aureus bacteremia. It is taken from golden grapes of wrath, a review. So when a patient suspected Staphylococcus bacteremia, empirically we start with vancomycin or cefazolin and thorough history and physical examination, like previously what we mentioned, source of infection, any prosthetic materials or any new back pain or musculoskeletal pain. And then we repeat the blood cultures every 48 hours until clearance. Echocardiogram, which previously mentioned, most important is pursuing the source control. And then once antibiotics we get based on the susceptibilities, we streamline them. So if the bacteremia is going to be complicated, like if there is a prosthetic valve endocarditis, or if there's persistent bacteremia for more than 72 hours, or there's no defervescence even within 72 hours of starting antibiotics and all, the duration of the antibiotics will go up to 4 to 6 weeks, whereas in an uncomplicated Staphylococcus bacteremia, it is up to 2 weeks. So in our patient, we started him with antibiotics, fluoxetine and rifampicin. We are planning for a total duration of 4 to 6 weeks. Source control and debridement was done, and there were no features of endocarditis, vertebral osteomyelitis, or endophthalmitis, and diabetic optimization was also done. Thank you.
Thank you, Shrithi. Are there any questions from the audience or comments? What was this patient's alkaline phosphatase?
It was 400, ma'am. We did a GGP, which was normal. It was probably sepsis related, is what we're thinking.
Or GGT was normal.
GGT
so then it's a
normal.
bone source, so it's because of the lenticulosis from the brain. And that's something that doesn't usually come with myeloma, so some contradictory findings. What did you do for source control?
Mild debridement alone, we did the vertebral the left sternoclavicular joint as well as supraclavicular abscess which was present. We tried to debride it.
So why do you think this patient didn't get better, even though he had a susceptible infection for 6 months? And
dissemination.
Yeah, one is source. Did he receive antibiotics?
They didn't have reports.
They probably did, because otherwise, why wouldn't the pus have grown immediately? So he probably received some antibiotics, probably an inadequate duration, and they didn't do source control. That's what. Thank you.